Welcome to tonight's webinar, everyone. Our topic this evening is Recognizing and Rebounding from an MS Relapse. My name is Ann Lee Gilbert, and I'm the Senior Specialist of Programs and Online Education for Do MS, and I'm excited to be your moderator this evening. If you're not already aware of who we are and what we do, Do MS is a provider of lifestyle empowerment programs for people living with MS and their support partners. Through our programs, we help to empower people to actively co-manage their disease and move beyond their MS by adopting active and healthy lifestyle behaviors. And you can learn about some of these programs by going to our website at www.mscando.org/programs. You can learn about our flagship 4-day program that's held once a year in Denver called the Can Do program. We also have our 1-day Jumpstart programs that we take around the country about 5 to 6 times a year. And we have our 2.5-day program called Take Charge. And of course you also know about our webinar series, and you can view all of our archived webinars on our website and also register for upcoming webinars. So please remember to visit our site. You can also connect with us on social media. We have a Facebook page where you can find all the up-to-date information regarding our upcoming programs and events. You can also connect with us on Twitter and receive some of our most up-to-date tweets about our recent happenings. And you can also find us on YouTube where you can browse some older webinar recordings and other fun videos put on by Do MS. And so just a few housekeeping issues that I'd like to go over before we get started. We will be saving the last 10 to 15 minutes of the webinar for your questions. So if you do have a question, you can chat them into us. And so if you look at the bottom left hand of your screen, you should see a little chat box. And you can just type in your questions, hit send, and the presenters and I will receive your questions, and we will flag your questions and have them answered by our presenters at the end of the program. And also because this webinar is being recorded, I have muted everyone's telephone lines, so you will not be audibly heard throughout the webinar. And before I get started, I'd like to now introduce our esteemed presenters for this evening's webinar. On your screen you see Ms. Gail Hartley. Gail Hartley is a nurse practitioner specializing in the care of persons with multiple sclerosis at the Arcadia Neurology Center in Arcadia, California, and at the Multiple Sclerosis Clinic at Casa Colina Center for Rehabilitation in Pomona, California. She is involved in both clinical practice and research trials for multiple sclerosis. Ms. Hartley earned her baccalaureate degree in nursing at California State University, Los Angeles, and her master's degree in nursing at University of California, Los Angeles. She holds certifications from the American Nurses Credentialing Center and the MS Nursing International Certification Board. She is an active member of the Consortium of MS Centers and International Organization of MS Nurses. She also serves on the Clinical Advisory Committee for the National MS Society Los Angeles chapter. She is a consultant and speaker for us at Do MS, and additionally she has been a contributor to several MS publications and co-authored several articles published in the International Journal of MS Care. And our final presenter is Ms. Susan Kushner. Sue Kushner has been a physical therapist for 28 years. She graduated from the University of Pittsburgh undergrad and graduated from the Physical Therapy School at Columbia University. She is currently finishing her PhD in exercise physiology at the University of Pittsburgh. She has been with Do MS for 23 years, and she has been on the faculty at Slippery Rock University for 21 years in the Graduate School of Physical Therapy. She works clinically doing home care physical therapy. Sue has also volunteered with the National MS Society for 22 years, both at the local and national level. This includes community work, volunteer speaking, treating patients, writing, and editing. And in 2006, Sue was awarded Volunteer of the Year by the National MS Society. She's on the editorial board for Momentum magazine, the client publication of the National MS Society. So I'm very, very excited to welcome everyone and to welcome Gail Hartley and Sue Kushner on this webinar. And I'd like to now hand it over to Gail.
Thank you, Ann, and welcome to everyone. So for those of you who are living with MS, you may already know that the majority of patients with MS are diagnosed with what we call a relapsing remitting disease. And that means that the disease is characterized by attacks, there we go, attacks. Sometimes patients call them flare-ups or exacerbations. And the definition of a relapse is that it's a new symptom or worsening of an old symptom that maybe you've experienced in the past. Those symptoms have to last for at least 24 to 48 hours to really be defining as an exacerbation. There shouldn't be any other medical condition or infection to explain the symptoms. And the symptoms generally last for days to weeks. In my experience, a lot of patients don't know whether they're having an exacerbation. And often they come to the office saying, I think something's happening to me. Something's changed, it's different, but it's hard for them to define. And sometimes the neurologic exam clearly shows some differences, but often things are kind of subtle. I think, Sue, you have patients who might come to you during therapy and say the same things.
Correct. And sometimes, as Gail mentioned, it's easily recognizable that something big is going on here. Sometimes the changes are subtle, and the patient may not know, what the heck is going on. They think, well, I just have a bad cold or a urinary tract infection, but this can be classified as a relapse or exacerbation.
Yeah. I think the one thing that's important for patients to recognize is that if you are feeling some new symptoms and they only last for a few hours, that is not an attack. That's just a little flare-up of a symptom, but it's not actually a relapse. A relapse has to be new symptoms that last for at least 24 hours. Now, we don't know exactly what causes relapse, but there may be inflammation in the central nervous system caused by some increase in immune activity, but we don't know what triggers it. Even when patients come in with a new exacerbation and we may be concerned enough to get a new MRI, we may not see a new lesion at all. It may look completely unchanged from previous. But that doesn't mean it's not a real exacerbation. It's just the MRI doesn't tell us everything. The other thing is patients often tell us that stress causes exacerbations, and there's no question that stress of any kind, whether it's a physical stress or a psychological stress, can affect our immune system in some way. So I don't discount it, but it doesn't really matter exactly what the cause is in a situation like that, unless it's an infection, which I'll talk about in a minute. We're going to treat it the same way, particularly if these symptoms are bothersome enough to bring you into the office and you're concerned about them. We're going to be investigating and treating that aggressively. Sue mentioned that sometimes people will have an infection or a urinary tract infection or a cold or something, and their neurologic symptoms, numbness, tingling, or weakness, more fatigue, may be worse under those conditions. And again, in those situations we need to treat the underlying infection and get you better, and when we do that, then your symptoms will get better as well. Another thing that can cause what we describe as a pseudo-relapse is overheating or a rise in body temperature. Even a change of a half a degree can cause more numbness, tingling, or weakness. And that's not an exacerbation, because as soon as you get your body temperature back to normal, your symptoms will abate and your strength may return. That's an important thing for you to consider in physical therapy, correct, Sue?
Correct. And also, I would like to add what would not be classified as a relapse but can really make you feel totally wiped out or flare up some symptoms is if a patient really overdoes some physical activity. Say they're not used to hiking a lot or being out in hot, humid weather, and they go to, Missouri for a vacation, and they overdo it big time, that can cause some symptoms that might mimic a relapse, but usually will not totally throw a person into a full-blown relapse. But you have to be very, very cautious of an increase in the symptoms due to overactivity, and like I said, some other factors such as environmental heat, humidity, lack of sleep, increased alcohol, increased caffeine intake, all of those things that sometimes really do all of us in.
Right. Really important for people to know their own bodies and
Correct.
know what those triggers might be for them. A couple of other things that would not be considered relapses are side effects of medications that might make one feel more dizzy or more tired, for example. And another thing is many women experience worsening of symptoms during their menstrual cycle. And that's not an exacerbation, but something that women have to be mindful of and know how to manage through in situations like that. So there are many symptoms that can occur for MS relapses. Our nervous system is very complex. Different areas of the brain and optic nerves and spinal cord send messages to different areas of the body. And so there can be any kind of change, including changes in vision or pain in the eye, and that's an optic neuritis, a very common presentation of multiple sclerosis and also a very common symptom in relapse. Sometimes patients have dizziness or problems walking because their balance is affected, or they have numbness or tingling. One of the things that patients often describe is something called we call it the MS hug, where there's kind of a squeezing sensation around the chest or waist. It's pretty common in patients who may have lesions in the spinal cord in particular. Those patients may also have some weakness or changes in bowel or bladder function, some urgency or frequency with urination. And there are two other things that can occur but are sometimes subtle so that patients have trouble describing. They have increase in fatigue, and this may precede some of the other MS symptoms. And the fatigue is quite profound and getting in the way of you going about your activities of daily living. And patients can also have cognitive relapses, which they have more trouble with word finding. They may have just slowing in their thought processes and their ability to process information and go about their daily activities. So those are things that should really be reported if they persist more than 24 hours. So in terms of defining a relapse, we have to do a couple of things. First of all, I have to listen carefully as a healthcare provider to what's the story been. When did your symptoms start? How severe are they? Have they been getting worse or better? How long have they persisted? And then I look at the physical exam to see if there are changes in the neurologic exam, if you have any weakness or stiffness, for example. And then we always have to rule out any contributing factors like infection or changes in your sleep or anything like that. The question always is, does it need to be treated? Not every relapse does have to be treated. Some relapses can be very mild, just some numbness or tingling that don't interfere with function at all. And in those situations, we may just treat symptomatically, make sure you're comfortable, these symptoms aren't interfering with your sleep, for example. But if they are preventing you from doing your activities of daily living, then that's a much more concerning process, and we need to be more aggressive with that therapy. Oops. So how do we treat it? we generally use high-dose steroids to reduce the inflammation in the central nervous system. And this is generally a treatment that we give intravenously at home. Most of our patients do not have to be hospitalized for this, and we give a gram a day for 3 to 5 days. Now for those people in Canada, they don't use IV steroids, they use oral steroids instead. We can also use an injectable form of adrenocorticotropic hormone instead of IV steroids for patients who don't have good veins to put in an intravenous catheter, or for people who have not been able to tolerate steroids in the past. So there are some side effects to the steroid treatments and to the ACTH treatment. There can be elevations of blood pressure. Most common things are some stomach upset. People can be hungrier or thirstier than usual. They can have trouble sleeping. People can be a little crabby when they're receiving steroids, so they can be a little moody. And there can be some increased risk of infection when you've had the steroids or in those first couple of weeks afterwards. Some longer term problems, which we don't see very often but are potential risks for osteoporosis, which means a reduction in your bone density. There can be cataracts. There can be damage to some large joints. But again, we don't say that very frequently. But these are things we have to be mindful of all the time so that we can reduce the impact of the steroid while it's necessary to use it though for your treatment. The other thing we do during when we're treating relapses, we have to address the symptoms that you're experiencing. Any painful sensations must be addressed. We might use medications to reduce muscle spasms and stiffness, and then of course medications to minimize the side effects of the steroids. At this point, we usually don't have patients start physical therapy during the exacerbation. But once our treatment is over, that's when we're going to refer our patients to physical therapy. So Sue, tell us what you can do to help us.
Thank you, Gail. What I would like to say to everybody is that you have to use your common sense before, during, and after a relapse. If you are feeling so wiped out and not even sure that it's a relapse, as Gail mentioned, that might be the time to seek the advice of a physician, nurse practitioner, get to the office and see what is going on. If you are diagnosed with being in a full-blown relapse, as a physical therapist, I would say, again, listen to your body. You may need to back off from what you're doing for a few days, even up to a few weeks. That may not mean totally laying around and cutting out all activity. Just, again, use your common sense in conjunction with your healthcare providers, physician, nurses, PT, OT. You may need to just really do a small amount of activity, just to keep the body going. And you may need a day or two or several days of lying around on the couch. But again, you really, really have to use your common sense and listen to your body during this phase. This is never a time to start an exercise program from scratch. If you've been thinking about it, for a year, year and a half, and you're finding, oh, I think I'm really getting worse, now should be the time maybe I should start an exercise program. I would say a big NO to that, because you may or may not be in a relapse. Wait till the body quiets down and then get a nice evaluation, thorough evaluation from your healthcare professionals, particularly a physical therapist, and you may be starting from scratch. If you have an ongoing program, you may just need to, again, cut back or modify for a time being. As Gail mentioned, and I think most everybody knows, that physical recovery from any relapse, like the disease of MS itself, can be highly, highly variable. You may bounce back to where you were in no time at all. It may be a long, slow ride back to where you were, over several months, 3 months, 6 months. Sometimes you may not quite regain absolutely everything that you had previously, and some modifications may need to be made. So I would say that the spectrum of the return from relapse is as wide and varied as the spectrum of the disease itself. But I do want you to keep in mind that before you get back to everything that you were doing, a reevaluation is highly, highly necessary from your physical therapist. So you want to get clearance and, before you move ahead. Hopefully your medications will be regulated by that point. And as Gail mentioned before, keep in mind some of the negative side effects from the short-term medications that you might be on. I will bring up insomnia from the steroid treatment. If you are not getting a good night's sleep and you still have to function in everyday, daily life, all of your ADLs, family life, work life, etc., you may not have 1 extra ounce of energy to exercise. So keep that in mind till things get a little bit more regulated with both the relapse and hopefully coming out of that, and getting the body and the medications back on track. You don't want to push your body and add any more stress to the already stressful situation that the body is perceiving from this exacerbation. As I have on this slide, the modifications may be very, very small that need to be made to your program, such as cutting things in half for a time being, or they may be very large. You may have been a runner and you may need to switch to walking or running on a treadmill. They may be short-term modifications that are needed, or as I mentioned before, some long-term changes that might need to be done to your program. If some modifications are needed, again, do that in conjunction with your physical therapist. You may need to decrease time that is spent in your cardiovascular activities so that you have some energy for strengthening programs, or vice versa. You may need to, instead of, again, walking or running outside on the streets, especially, say, in August in the Deep South, you may want to be working out inside on a treadmill with air conditioning going, or some ice packs or cold towel around your neck. You may want to switch to a nice cool swimming pool or aquatic workout. Even if you're not a swimmer, there's so many great things that you can do in the water. You may switch to a stationary bicycle versus a road bike. If your balance is a little shaky for a while, or your vision is not as clear as it had been before the exacerbation, a stationary bike indoors might be safer for you for the time being, possibly permanently. If you are an active yoga or Tai Chi or Pilates participant, you may just need to modify and cut back on those sorts of activities also. A lot of people find that they can still do those activities throughout the course of the disease, just with some slight modifications as time goes on. Keep in mind, too, this might be a little change in what is needed as far as adaptive equipment and durable medical equipment is needed. Always keep in mind that the toolkit that physical therapists have for adaptive devices, they are so useful, so important, and please tell yourself that this is not giving up, this is not giving in, this is being smart. This is using something in the category of assistive devices that is going to save you a lot of grief in the future. It can add to the energy that you have available during the day. It will certainly add to your safety. If you, through this flare-up or exacerbation, if you find that you're having foot drop and you never had it, well, believe me, the last thing you want to do is incur a fall. Sometimes I'll give people the worst case scenario just to scare them a little bit. You do not want a fall that might result in a broken bone and casting, or worst case scenario, surgery, pins, plates, immobility for 4 or 6 weeks, and then rehab. So you want to use assistive devices to help get you through this exacerbation. Sometimes they will be assistive devices that you and your therapist will find may be a permanent addition and a positive addition to your programming. But again, that's unpredictable, but keep in mind that adaptive devices, durable medical equipment, can be so helpful in the long run. This category includes braces, maybe changing from one cane to forearm crutches or regular crutches, or a wheeled walker. You may need some wheelchair modifications at this point. But again, we are trying to save energy and increase safety for the long run. You may also be wanting to think about new interests or activities that are more compatible with the stage that you're at right now during the exacerbation and maybe even afterwards. I also mentioned saving energy, which I mentioned a little bit before. You may also want to consult an occupational therapist in this category. They have so many great little tricks of their trade for activities of daily living, dressing, computer and workspace analysis. I mean, they just have so many great suggestions that can be offered to you. Instead of doing a 30 or 40 or 20-minute workout per day, you may find that 2 or 3 10-minute workouts per day do much better for you during the relapse or even afterwards. Always be seeking something that is going to work for you. I always tell patients, if it works for you, it works. That means that, you know, if we tell you to do 40 minutes 3 times a week and that's just not going to be right for you, modify it. Find something that you like and that you are able to continue with over time. A lot of people like to do individual exercises in the privacy of their home at 5 in the morning or midnight. Other folks get extremely energized when they go to a class or the local community gym, and it's a great social network. So find what works for you during and after any exacerbation period. Again, these may be temporary changes. They may be more along the lines of permanent changes. As Gail mentioned, it is unpredictable how long a relapse may last. Even the physician, the MRIs, the nurse practitioners, nobody has a crystal ball to predict that. So please be patient. I have in capital letters here, do not stop exercise. Again, use common sense. If you are so wiped out from a urinary tract infection or full-blown exacerbation where you are on the couch, you're going to have to stop exercise. But keep in mind that it will be something that you will pick up hopefully sooner rather than later, or be continuing with the modifications that I had mentioned before. And keep in mind, you always want to get the main categories that we like to sing the praises of strength, balance and coordination, cardiovascular health, maintaining your weight, and it's proven umpteen times in 30 or 40 years the great psychological benefits of exercise. And I also like to mention that just because you have MS, that does not give you a get-out-of-jail-free card for every other disease and lifestyle disease that can catch up with all of us as we age. You're still going to be susceptible to cardiovascular disease from inactivity, as many Americans are. You're still going to be highly susceptible to diabetes if you are overweight or do not have a proper diet. So again, you have to keep in mind lifestyle diseases that may be creeping up on you parallel to some of the problems that arise over time with MS. So I like to mention also that new or modified activities can be enjoyable. You can find new friends. Maybe your partner always wanted you to do something a little more sedate with him or her, and now, you know what, they're going to be happy that you actually have to slow down and they can keep up with you. Sometimes we find, especially in a lot of the can-do programming, we find that people for the first time in their lives are exercising due to their MS. A lot of people have just been, avoiding the something that they don't like, such as exercise, and the diagnosis of MS is kind of a kick in the pants and finally gets them to doing what they should have been doing all along. I've certainly had more than one patient at various can-do programs say that in some ways the MS really was a good thing for me. It got me back on track, had me quit smoking, do weight loss, starting to exercise for the first time in my life. I also like to emphasize that the local chapters of the National MS Societies have wonderful group activities for folks with MS, aquatic activities, yoga programs. Depending on what area of the country and what city you're in, there's a huge variety of programming. And please always make sure that you have a healthcare team, all the providers and the professionals that know MS. You're not going to go to a knee specialist, an orthopedic specialist for MS. You want to make sure that all of those people know the disease and its nuances extremely well. And they can help you not only through the relapse and exacerbation, but throughout the course of the disease. And then staying healthy with MS, I will pull Gail in here again with some of the disease-modifying therapies, but I do want to just mention some of the things that we preach all the time: the healthy diet, normal weight, regular exercise. Adequate sleep cannot be emphasized enough. Even though your sleep may be interrupted during the exacerbation, it's important to try and maintain a normal sleep habit. Is that correct, Gail?
Absolutely. Sleep is not very well respected in our lifestyles in the United States. We really need to, however, change the way we think about sleep. It doesn't just happen. We actually have to plan for it as an activity and make time for it so that we're getting at least 7.5 to 8 hours of sleep. Some people need a little less. Most people need around 8 hours, and we should try and shoot for that. It's hard in a busy society, but really important for our overall health, our cardiac health, our sugar metabolism. All of that is affected by how well we sleep.
And weight control.
Weight control, absolutely. Absolutely. We have to learn to manage stress because we can't get rid of it. It is part and parcel of our experience on the planet. So really important for us to be able to find healthy ways to manage it and keep it under control. And then
Gail, after someone is done, or after the relapse has subsided, can they usually expect their sleep patterns to return to normal?
Yeah, they should. The steroids actually interfere with your ability to fall asleep or stay asleep. They're just activating. But a lot of people with MS do complain of sleep disorders. We have, sleep apnea. Patients with MS may have more restless legs at night, for example. And so those things need to be normalized. But a lot of the problem is that we don't pay attention to keeping regular sleep hours. We don't plan for enough sleep. We don't have environments that are conducive to sleep. We sleep with the TV on. We're falling asleep in front of the TV, and that just doesn't make for good restorative sleep.
Every week at least I see in one of the several newspapers I read an article on the perils of lack of sleep, and it doesn't matter what age, but weight gain and cognitive function and on and on and on, just
and mood.
How detrimental. Right. Yes.
Right. So I'm going to circle back here just for 1 minute to talk about relapses and disease-modifying therapies. So when we talk about how could we possibly prevent a relapse, some of these lifestyle strategies really do help keep us in homeostasis or keep our body in our normal rhythm. But when you have MS, there is this potential for more relapses. And one of the things that we have learned over the last 20 years is that if we address that multiple sclerosis with a disease-modifying therapy, we can reduce the number of relapses people have over time. We can reduce the severity of those relapses, and we can reduce new activity on the MRI. And by doing those things, we can delay disability. And when patients have a relapse, when they are on a disease-modifying therapy, that's the time to have a conversation with your healthcare provider about whether this is still the right therapy for you to be on, or is it necessary for us to make a change? So those are things that need to be discussed. I think the important thing in all of this is what Sue and I are saying is that it takes a team to take care of MS patients. The patient really is at the center and is responsible for a lot of these lifestyle strategies, making sure they're getting enough sleep and eating right. But your physician, your nurse practitioner, and all our rehab therapists have to work together to manage this disease over time. What would you say, Sue?
Definitely. And almost every patient group that I ever deal with, or every individual, I like to tell them that they are the cog in the wheel. They are the ones that should be the captain of the ship. The patient should be. They need to be the squeaky wheel that gets oiled. And in today's healthcare system, you have to push, push, push. You have to be aggressive. You have to get what you want and get what you need. And like I said, being the cog in your wheel is extremely important. People are not going to be knocking on your door and saying, oh, would you like this? We heard you could use that. Would you like to try this new ankle foot orthotic? You have to be the one demanding the things that you need.
You have to advocate for yourself. Yeah.
Correct.
Okay.
Great. Well, thank you, Gail and Sue. And we're now ready for our questions and answers. So if you haven't chatted your question yet, please feel free to do so. But I did want to address some questions to our presenters, and a lot of these questions came in from our registration form for when people signed up for the webinar and through our chat feature. And Gail, you had gone through this at the beginning of the webinar, but we got an overwhelming number of questions about this, and I thought maybe you could go over it again. And the question is, how to first recognize signs of a relapse, and how do I recognize that it's a relapse versus an ongoing symptom? And then the second part of that question is, when should I call a doctor, and how long should I wait to call?
Okay. So I mentioned earlier that you are the expert of your body. You know what's normal for you, and for some MS patients, having numbness or tingling or occasional problems with balance is the new normal. It's not exactly normal, but these are the things that you may have intermittently from time to time, or maybe constantly at a low level. A relapse is when any of those symptoms is dramatically worse, or if you have a brand new symptom that you've not had before, and either of those things comes and stays for more than 24 hours. And when that happens, that's the time to pick up the phone and call your healthcare provider and say, something's definitely different here. And most of the time, your healthcare provider is going to say, come on in. We want to see you. Did I answer that completely?
Yes, you did.
Okay.
No, thank you for that. And I think it just needed to be repeated for some of our viewers who are asking the question. So thank you for that.
And to just add on to that, I don't mind if patients call me to ask, should I be worried now? Because if you're worried, it's worth a call. And I'm happy to answer those questions. And sometimes I'll just say, let's watch it for a day. If it's not really getting in the way, it's not painful, you can still do everything, we might just watch it and see how it goes. But if it's really interfering with function, then I want to know about that so that we can intervene early.
Great.
And always better safe than sorry, correct, Gail?
Mm-hmm.
Better to come
sure.
in, and be told, No, don't worry. Go ahead home. It should be no big deal. Then stay at home and suffer and really find that you've lost a lot of ground.
Right. When we could intervene early and get you back on your feet quickly. Right.
Great. We also got several questions about the different stages of MS. And the question is, how do I know if this is a relapse or if my MS is becoming progressive?
Well, that's a difficult thing to answer because it can look different for every single patient.
Right.
But usually progression happens very subtly over time, and there's no question that people that have lived with MS for a long time can have some progression that is not associated with an acute change in their neurologic function. But upon questioning, I might say to someone, well, can you walk as far today as you did 6 months ago or a year ago? And they'll say, babe, no, I really can't. And that's been a very subtle change. In those cases, treatment like an exacerbation may not be appropriate, but certainly we want to involve our rehab therapists at that point to see if we can make things better, because sometimes that's just deconditioning. Correct, Sue?
Oh, very much. And sometimes it's hard to distinguish what is deconditioning versus what is a slow, a very slow progression. Also, we all like to often ask questions to the support partners, to the folks who live with the patients, and say, hey, what do you notice? Because a lot of times the patient themselves might not notice these really subtle differences, or they may choose to just kind of brush them under the rug, whereas somebody that is an inside observer but not the patient can give us some information that can really be valuable to us as the healthcare providers that are trying to kind of piece things together and help solve the mystery.
Excellent. We also got a number of questions about steroids, and the question is, are steroids the only option outside of rest to rebound from a relapse? And are there any other options for helping the relapse?
Well, steroids or ACTH have been the standbys forever, I think. ACTH was used back in the 1960s and 70s before we had Solumedrol, and the Solumedrol was available and was easy to access. And so those have been the standard treatments for exacerbations. Some oral steroids are also used. As I mentioned, in Canada, that's pretty standard. But there isn't really anything else that we're using for acute relapses at this moment.
Okay, great. And then we have another question asking, how might optic neuritis be differentiated from a migraine headache?
Well, optic neuritis doesn't often have a headache associated with it. But there may be eye pain and redness and changes in visual acuity. Occasionally there are patients who have a complicated migraine in which they do have changes in vision, some blurry vision and that sort of thing, but that is a completely different presentation. So.
Okay, great. Let's see here, just filtering through our questions. And okay, so this person's asking, I think this is for you, Gail. Just to clarify, it said that a relapse is only when there are new symptoms presenting. However, I've had the same symptoms last for days and weeks, which have been classified as relapses. Can you help clarify this?
Well, it's different for every patient, but generally speaking, it is either new symptoms or significant worsening of old symptoms. So it just depends upon the degree with those old symptoms. Other things can influence numbness or tingling, for example, or someone may have numbness and tingling and it doesn't bother them much, but suddenly they have an infection and now they have burning there too. Well, we need to treat that infection, and then those other symptoms may go back to their baseline. But yes, sometimes it's the same symptoms just keep coming back and flaring up. Sometimes we call it an exacerbation, and sometimes we don't. It just depends on the severity.
Great. Okay. I think we do have one other question here, and it sounds like it's a question that relates with cognitive issues and relapses. So it sounds like at the age of 37, I noticed that I was having cognitive issues and was ultimately diagnosed with adult ADD. I didn't have these issues in the past, and I was diagnosed with MS at about the same time. Is there a connection with this as a relapse, and is there a connection between cognitive disorders or cognitive issues and ADD with that and MS and relapses?
Well, that's complicated.
It is. I don't know if I explained that.
That's pretty complicated. But I'll say one can have ADD without having MS. And you can have MS and you can have cognitive issues which may or may not include ADD. So there isn't a specific connection between ADD and multiple sclerosis. I think that's the easiest way to answer it.
Okay, great. Excellent. Well, I think we did get to most of the questions that came in. I'm just trying to filter through these again. Here's one. Can and does steroids negatively impact fertility?
No, not to my knowledge.
Okay.
We would tell someone, I don't think while you're receiving high-dose steroids at the time you should try and get pregnant, however.
Right.
But I would say there are no long-term issues with regard to fertility with steroids.
Okay, great. So I think that we've answered most of the questions that we can get to this evening. So thank you so much, Gail and Sue, for tackling those questions and providing some answers for us and for this awesome webinar. If you do have questions for those that are participating that you'd like answered, you can submit them on our website. If you look on our screen here, we have what's called an Ask the Can Do team. If you go to our website at mscando.org, you can submit your question, and one of our programs consultants will get back to you and answer those questions for you. So that's a great resource that we do have. We also have our Can Do library, which is a library of articles written by all of our programs consultants on a variety of different topics that you can catch up on. And you can also view some of our monthly e-news articles that will keep you up to date on all kinds of things that's happening with Can Do MS. So we appreciate everyone that's participated in this webinar tonight. And we hope that you can also join us for our next webinar on September 9th. The topic is MS Symptoms Part 2. It's our Part 2 of our two-part series on MS symptoms, and it's managing your mood and cognition issues with our psychologist Peggy Crawford and our speech-language pathologist Jeff Hodgson. So please remember to register for that at mscando.org/webinar. And just to remind everyone, everyone who is participating tonight will get a copy of tonight's slides emailed to you, and the recording for this webinar will be available on our website tomorrow. So again, thank you so much everyone for participating, and Gail and Sue, and a special thank you to you for being able to provide us with so much of your knowledge and expertise on the topic.
Our pleasure.
Thank
you for having us.
Good night.